I would now like to introduce you to our second speaker. Dr. Carton Costello is an Australian-based health professional. Dr. Costello is an intensivist and has extensive experience in echocardiography. He's author of numerous scientific publications regarding echo. Education is his true passion, and he has been training doctors in the echo for many years. I would now like to hand the presentation over to Dr. Carton Costello.
Thank you. It's a pleasure to have the opportunity to speak to you all about the practical application of infection control to point-of-care ultrasound use. There's been an exponential growth in recent years with the use of outside of the traditional departments of radiology and cardiology, and that goes across multiple subdisciplines of medicine, and this is point-of-care, so-called pocus, point-of-care ultrasound. It's particularly had a rapid uptake in intensive care, where ultrasound is not just used extensively, but its use is mandated in various guidelines for such procedures as insertion of central lines, any procedural insertion within a body cavity, but it also forms part of the standard treatment algorithms that we use for cardiac arrest, pulmonary embolism, and indeed it's a mandatory part of our education curriculum. I would go so far as to say that almost every patient admitted to an intensive care unit has point-of-care ultrasound as part of their care, with many patients having multiple ultrasound scans of different modalities. Now, why is this relevant to infection control? Well, if I consider my own unit in Wollongong in New South Wales, the only piece of medical equipment that moves from bed space to bed space and touches the patient that isn't a disposable piece of equipment is the ultrasound machine. And it is self-evident there that there is an infective risk of transmission from patient to patient. Now, the use of ultrasound is mandated, but what hasn't come with mandated use has been mandated funding. And unfortunately, point-of-care ultrasound finds itself in a dilemma of an ad hoc funding model, which negatively impacts on infection control. And while we have machines are present, high-quality machines are present in almost every intensive care in Australia and New Zealand, what really is lacking is safe infrastructure for the deep, safe, well-funded infrastructure for the wider safe practice of point-of-care ultrasound. Now, this applies to such issues as it's easy to get hardware purchased, but it's very difficult to get funding for software, IT support, education, and unfortunately, infection control also suffers from this poor ad hoc model of funding. The consequence of this poor infrastructure, unfortunately, has been a culture of poor standards within the POCUS community across all of these domains, but that includes poor infection control standards. This 2015 study from Queensland, Matthew Key and his colleagues looked at equipment from 5 intensive care and ED departments, and unfortunately they were able to show extensive contamination with blood and microorganisms, which really is a damning indictment of how we practice medicine. In fact, none of the departments studied had protocols in place for how they would clean these machines. Let's consider the regulatory environment within which point-of-care ultrasound is practiced. There really is quite an extensive, it's perhaps opaque and poorly written there's a lot of guidelines, there's standards, there's accreditation values, etc., that did exist, but they were quite, I suppose, they weren't particularly well known to the point-of-care ultrasound community. Thankfully, in 2017, ACPIC and ASM really pulled all of these together in an excellent document that clearly outlined what the standards were and what was needed to be done by practitioners, depending on what type of study that they were prepared to do. So these guidelines were quite well accepted within the wider ultrasound echocardiography community. There was good acceptance that this was a major step forward, and I think there was, while it isn't perhaps documented or measured, there was a wide improvement in the practice of infection control with the use of ultrasound. But there was many, but there was not, but this really wasn't mirrored in the POCUS community, where concerns were really being expressed about the practicality and the cost of implementing guidelines, and particularly as it related to central line insertion or arterial line insertion. Indeed, the College of Intensive Care or Emergency Medicine, ACAM, issued a statement of concern about the ability of their ability to really to work with these guidelines. Quite a few fellows of the College of Intensive Care wrote to the college, and they too were very concerned about their inability to comply with what they felt really were standards to which they were obliged to comply with. And so the board of the College of Intensive Care asked the ultrasound special interest group to look into what are the relevant issues for infection control as POCUS is practiced in intensive care. So when we did actually write these guidelines, they were published in 2019, just at the beginning of the COVID pandemic. But I think it's worth bearing in mind that really we were being asked to write these with a view perhaps to expressing concerns as to the practicality and the cost implications. But that's not how it turned out. So what I'd like to do in the talk really is not so much go over what the guidelines say, but I'd like to discuss the thoughts and the rationale behind the guidelines that we put forward. So we started with the ACPIC 2017 guidelines, and they in turn are based really on standards produced by Standards Australia, which we've already seen that probes really are classified as reusable devices. They're disinfected as they can't be practically sterilized, and the level of infection depends on risk. Risk is determined or outlined by the Spaulding classification, which basically which categorizes 3 levels of risk, but takes that and advises that the impact or the consequence of risk classification is either a low level or a high level disinfection. So we start with 3 levels of risk classification and lead to a binary outcome of high level or low level. That's not to say that there isn't an intermediate level. There is an intermediate level of disinfection that does actually have quite useful increased spectrum in killing some of the mycobacterium and fungi and other bacterial things that are relevant to the practice of point of care ultrasound. But leaving that aside, the Spaulding classification is really forms the basis of risk assessment. And in its calculation or estimation of risk, it very much relies on where the probe is going to be placed. Now, if we consider what methods of disinfection there are, while there are many different products on the market, they can essentially be broken down into 2 types. You can either have chemical disinfection or rely on ultraviolet C. So Spaulding basically considers where the probe has been, but in producing the 2017 guidelines, there was an extension of really criteria as outlined by a rigid adherence to Spaulding classification, where it also, the guidelines advocated that if a probe had been in contact with bodily fluid, that it must receive high-level disinfection. And this actually has important implications for CVC insertion, where obviously it's not just in inserting a line with a sharp needle that there's a risk of transmission of pathology, but also there's a high probability that that the probe will be exposed to blood. However, when we were writing our guidelines for intensive care, we actually took a step back, and we felt it was important not just to consider microbiology risk factors alone, but to consider much wider factors that included workflow, cost, practicality, and the human factors that are relevant to a comprehensive program of prevention of pathogen transmission. I put it to you that all of the preceding guidelines to the ones that we've produced at UCIG, that they very much, I think, begin with the premise that ultrasound is practiced in largely outpatient settings with clean, cooperative patients, with studies being undertaken by technicians that have the unitary task of to take the image, and they've then got all the time in the world to clean their machine. Another important difference is that these outpatient or even inpatient facilities from cardiology and radiology are well funded. Now, point of care ultrasound that it's practiced in ICU, and this would hold true for emergency departments or any other setting, are profoundly different. The way in which we acquire these images dramatically impacts infection control. And I think we need to take a little time here to consider this. So first of all, we do many different types of ultrasound in intensive care. We do simple transthoracic echoes, and these might only be 1 or 2 images, that's on the right, but we also do semi-invasive procedures such as central line insertion and transesophageal echo. The consequence then of this is, even using Spaulding, is that high-level disinfection needs to be available just as much as low-level disinfection needs to be available. And for this reason alone, this really is a profound impact. So the idea that high-level disinfection is seen as an exception or an extreme event, we really need to lose this idea. Most of the echoes that we do are actually semi-critical, if not critical in nature. And the consequence of this means that either multiple machines need to be available or that disinfection cycle times need to be kept short. And this is an important consideration. I've already said that the echoes or ultrasound studies performed in point of care really are undertaken by not dedicated technicians, but large numbers of doctors with various levels of skill, both in ultrasound and echocardiography, but also in infection control. And there is actually a very, very high burden of training that would be required to bring everyone up to speed. The current practice of who's asked to clean and disinfect ultrasound probes really at the moment is the doctor. And this is unusual because doctors aren't actually tasked with disinfecting any other piece of equipment. Now, the problem is that doctors have other simultaneous clinical tasks. And so we've created a situation where infection control competes in a zero-sum game with patient care, and it negatively impacts on infection control. The environment within which we perform point-of-care ultrasound is heavily contaminated with blood and fecal material, not to mention spores as well. And so, again, this means that high-level disinfection needs to be considered as routinely available. Something else that ACPIC considered was the 2017 guidelines talk about probe disinfection. But the probe is attached to a machine which is exposed to the same environment. And so in producing the guidelines, we sort of made a pragmatic decision to divide the machine into high touch areas or high frequency touch areas and low frequency touch areas, and basically provided guidelines as to how and what level of disinfection they need to be cleaned. Basically saying that the high touch areas need to be cleaned to the same risk profile as what the probe is. So trying to pull together the specifics of how we practice point-of-care ultrasound in intensive care that are relevant, the key issues are that we need high-level and low-level disinfection need to be available as standard. Multiple machines need to be available with rapid turnaround time. Disinfection needs to be carried out by staff who are resourced in time, equipment, and training, and we need to clean the whole machine. And really, that was what brought us to produce our guidelines, which we divided into three divisions. We produced general guidelines, specific, and COVID-19 recommendations. I'm not going to go through them, but I would like to just talk about 1 or 2 topics. What about CVC or ultrasound-guided insertion of catheter devices? Well, Spaulding, if we stuck with it, would recommend high-level disinfection in all cases, while the ACPIC guidelines actually made a compromise, saying that low-level was acceptable, provided that the transducer remained at some distance from potential contamination. Now, this was really in response to concerns from the ED community about cost and practicality. In ACPIC, we didn't accept this. We said that you needed to do high-level disinfection, and the reasons were as follows. That, first of all, high-level needs to be available anyway as standard. There remains a risk, as previously discussed by the previous speaker, but that the sleeves that cover probes really don't provide 100% guarantee. And we really felt that allowing clinician judgment based on distance to probe offered too much ambiguity, and there really would be a race to the bottom in terms of quality control. But the main reason also I think worth considering is there's absolutely very little difference in cost and practicality. Now, when we consider cost and practicality, again, we need to break down costs into two types. There's costs of capital purchase and consumable costs. But the bottom line is we went and checked them. Instead of being worried about it, we basically measured, and really a low-level disinfection can be performed for as little as $2, and high-level disinfection can be performed for as little as $3. And we came to the strong conclusion that cost and practicality were not meaningful barriers to the adoption of good infective control, good infection control procedures. But what about who cleans the machine? Because the real cost in actually cleaning machine is labor. I've already said that doctors are in a poor position to do this because of multitasking, difficulty to train burdens. The problem is when you try to discuss it at a hospital level, these discussions can get bogged down in sort of petty hierarchies between different craft groups. So what we did at ACPIC is we really produced guidelines that said whoever is cleaning it needs to be trained, resourced in time, and they need to have actual adequate financial funding. And so really, if I just whiz through really what we came up with in our general principles, we're saying that clinicians have a joint responsibility to minimize iatrogenic infection, but that is not to say that doctors should be tasked with the cleaning in an absolute sense. We also commented that single sachets should be used, that we should have cleaning as the first step in any procedure. And we stuck really with the 2017 ACPIC guidelines with the following exceptions. We went with high-level disinfection in all cases where ultrasound guides invasive procedures. The machine must be cleaned, and other stuff really is I suppose self-evident and not particularly important. And so really to conclude, I really do want to place infection control with relevant to point of care ultrasound. It really forms part of a wider discussion of the need to improve the deep infrastructure for safe practice of point of care ultrasound. The external factors that prevent good infection control really are the ad hoc funding models, but there is an internal barrier to good practice, and that is the culture. There's a culture of acceptance of poor standards within POCUS that we as a community need to address. So thank you for the opportunity to talk to you.
Thank you, Dr. Costello. Before we move on to our final speaker, here is our third polling question. The question is, in your emergency departments, to ensure safe practice in ultrasound use, have you introduced standardisation in staff training and ultrasound probe disinfection practices?